The enemies we fight against do not slow down. Cancer is relentless. Diabetes is relentless. Time is relentless. So we are relentless. We lose sleep at night dreaming of solutions for wearable technologies, remote monitoring, advancements, innovations, any weapon to win the fight. We are the men and women of Ochsner, and we are relentless. We're doctors and nurses and dreamers and healers, but above all, fighters. Yes, fighters.
Keep working it.
Because when it comes to your health, good is never good enough. So we do not slow down. Ochsner, innovating healthcare.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about cancer of the breast and lymphedema with surgical breast oncologist Aimee Mackey. In the second half hour of our program, we'll be taking your questions live by phone at 504-866-3200. That's 504-866-3200. And questions by email, too, at hhquestions@wlae.com. Dr. Aimee Mackey received her medical degree from the LSU School of Medicine in Shreveport. She completed her internship and residency at the Ochsner Health System here in New Orleans. She finished her fellowship in surgical breast oncology at the Columbia University Medical Center, that's in New York City. And it is our pleasure to welcome back to this program Dr. Aimee Mackey. Good to have you.
Good to be back.
It was almost a year ago
Yes.
that you were here. Any family news since then? Actually, I know the answer to that, but that's my job to ask that good question.
I was pregnant last time I was on the show, so yes, I had a little girl in January.
All right, so two girls in the family now?
Mm-hmm.
All right, terrific. And you're able to manage all of that and your professional life? And
I do my best.
But you're still a man-to-man defense, right? With
Yes.
you and your husband?
Yeah.
Yeah, okay, well, good. And
Not outnumbered
congratulations.
yet. Thank you.
That's right. Well, congratulations, doctor, and good to have you back again.
Thanks.
What are the current statistics on breast cancer? I wouldn't imagine there's been any real changes in a year.
No, not really. Roughly 1 in 8 women are going to be diagnosed with breast cancer in their lifetime. In 2016, about 250,000 women were diagnosed with invasive breast cancer, and about 40,000 women still died of breast cancer. So we have made a lot of progress in breast cancer over the last few decades, and there's roughly 3 million breast cancer survivors, which is why tonight's topic is so important.
A quick test, you hear everyone knows somebody or has somebody in the family who has had breast cancer. That is certainly the case in my family, family member. What about with you?
No one in my family that I know of, but definitely close friends of the family that have had to deal with breast cancer.
Certainly all been touched in
Yes.
some way. Tonight we're talking about lymphedema as it relates to breast cancer. So what is lymphedema?
So lymphedema is basically a collection of fluid in the soft tissues. So lymph is a clear, thin fluid that circulates different things and collects waste, collects bacteria, and tries to filter them. And edema is a pooling of that fluid. So lymphedema is basically a pooling of the lymph fluid in most commonly extremities.
Okay, and we're talking about it tonight specifically about breast cancer, but obviously it happens in other areas of the body. In that case, we saw it in the arms and hands, right?
Yes. So With breast cancer, we are sometimes disrupting the natural flow of the lymphatic system, and so it can definitely be a result of some of our treatments.
Yeah, so let's see, you brought an image along to show us how lymphedema and breast cancer fit together.
So this is a picture of the breast. Just classically when we're operating, we can disrupt the lymphatic system. So this is kind of a natural progression of how kind of a normal cell looks, and then how it transitions into an invasive ductal cancer, which is the most common type.
You talked about the lymphatic system and how the lymph works throughout the body doing the things it's supposed to do,
right.
But it can also be detrimental to us when it's involved in the spreading of breast cancer.
Correct. Right? Yeah, so the most common way that breast cancer spreads is through the lymph nodes. They are most commonly going out towards underneath the arm and the underarm area called the axillary region. We can also spread to the lymph nodes up by the clavicle, which is kind of your collarbone, and then also the lymph nodes underneath the sternum. And whenever we're operating and we're trying to stage breast cancer, we have to remove lymph nodes. And by removal of those lymph nodes, we then disrupt that system, which can then result in lymphedema.
Okay, I'm going to add a question here only because it is Breast Cancer Awareness Month, and I think probably not a whole lot of information has changed, but as far as screening and what women should do, what is the best advice you can give for women to get on the front end of breast cancer and breast cancer prevention?
So I know kind of there's some confusing guidelines out there, but we currently recommend starting annual mammograms, which is yearly mammograms at the age of 40 or 10 years younger than the youngest person in your family was diagnosed, whichever comes first. And then also just kind of being self-aware of what your breasts feel like. So doing, kind of
self-examination,
regular checks to see if you feel anything new.
All right, very good. Good advice. Current breast cancer treatment options.
So currently, whenever women are diagnosed with breast cancer, they come in and have a long discussion in the office, and we talk about the different treatment options. Today, they include a lumpectomy, which is just removal of the tumor and then a little natural rim of tissue around it. And then also we can do mastectomies, which is removal of the entire breast. And at either of those surgeries, we usually check or sample lymph nodes.
And this is where you might hear the term margins, right?
Yes.
So talk to me about the margins and what you're looking for when you're going into surgery.
So margins is we want to make sure that the cancer cells aren't touching the edge of what we take out. So it's most commonly encountered whenever we do lumpectomies. If those tumors can then microscopically extend out to the edge of where we did the lumpectomy, then we sometimes have to go back and take a little bit extra.
Okay, so in breast cancer, especially when you're removing the whole breast, there's reconstruction often that takes place. Some women choose that. And really a trend that we're seeing more and more of is immediate reconstruction. Talk to me about that process.
So whenever we do a mastectomy, which most of the time women have the option of which one they would undergo, whether it's the lumpectomy or the mastectomy, but some women have to have a mastectomy. And if you're having a mastectomy, we now do a lot of really great, we do nipple-sparing mastectomies, we do skin-sparing mastectomies where we can really preserve the whole envelope. And then the plastic surgeons come in at the exact same time and are able to reconstruct it either with implants or sometimes using their natural tissue from their abdomen.
And is immediate reconstruction, is that always an option or in some cases not?
It's not always an option, but a lot of times it is. There are kind of rare circumstances where we can't do immediate reconstruction.
Do we know what causes lymphedema and are there risk factors for it?
So we don't know exactly what causes lymphedema, so to speak, why one person might get it but another person wouldn't when they've had the exact same operation. But we know that there are certain risk factors, and those being in the United States, most commonly breast cancer treatment. So whenever we do mastectomies and we sample lymph nodes, whenever we remove all the lymph nodes, that's called an axillary dissection. That can increase the risk of developing lymphedema. Radiation therapy, which is commonly goes with a lumpectomy. Anytime you get an infection in the arm, obesity, and age.
You showed us the earlier picture of the person with the one very large arm and hand and the other. That would be a sign that there's serious issues.
Right.
But what are the signs and symptoms of lymphedema that may not be that obvious?
So most commonly it's going to happen within about the first 3 years of your breast cancer treatment. And usually the patients are coming in saying, my sleeve feels a little bit tight on my arm. I haven't really noticed too much, but it just kind of feels a little bit snug, or maybe their ring or their jewelry might be fitting a little bit tighter. That's a very common first complaint. Or sometimes it's just a heaviness or an ache in the arm when they've been using it.
Okay. And I would imagine that most women who have breast cancer surgery are hearing about this probably after surgery, right? These are the things to look for because these are possible complications.
Right.
Right.
Yeah, so whenever we're doing our initial consultation, it's really a lot of information that patients are sometimes having to take in. And I'm not always sure everybody kind of hears everything. So I think it's really important for us as the physicians to just kind of follow up with patients every time they come into the office for their follow-up visits. Those are things that we're looking for and monitoring for them.
And I guess it's human nature too. When you say, now, not everyone's going to develop this.
Right.
Most people think, okay, great, that's me.
Right.
I'm the one who's not going to develop it.
Right.
Next, you brought along a series of images that kind of take us through the stages of lymphedema.
Yeah, I think classically, we didn't really look for lymphedema. So patients got their breast cancer treatment, and then they would kind of go on about their life, and then next thing you know, they're coming in and they have this really, really big swollen arm, which is kind of all the way to the right of the screen. And now we're really doing a good job on the front end of trying to monitor these patients. So we're really trying to catch it earlier, because the earlier we catch it, the better our options are.
Okay. There are some things you do as surgeons and physicians in the office to try to prevent it, and then there are things patients can do.
Right.
Again, no guarantees,
right.
but there are things that you're doing and things patients can do to lessen their chances. So let's start with what's happening at the doctor's office.
So historically, if you go back maybe 30 years, we used to remove all the lymph nodes under the arm. That's an axillary dissection. And the risk of developing arm swelling or lymphedema was probably in the range of 20% or so, 15, 20%. The literature is kind of all over the place.
And the reason you were taking out, you just wanted to be safe, right? You wanted.
Correct. It was for staging.
That's right.
We were trying to see if the breast cancer had spread. We knew that there really wasn't any survival benefit to removing those lymph nodes. We're not making patients live longer, but we needed to know if it spread because we needed to know how aggressive we needed to be. Mm-hmm. And so some really smart people in the 1990s said maybe we don't need to remove all of those lymph nodes. We can remove maybe 1, 2, or 3 lymph nodes. And by doing that, that's what that first line is, a sentinel lymph node biopsy. We lowered the risk of developing arm swelling or lymphedema by all the way down to only about 5%.
What's an ARM?
So ARM is axillary reverse mapping. That's another technique that we've started using where we're trying to see, okay, we know that there's certain lymph nodes that drain the arm, and we know that there's certain lymph nodes that drain the breast. And we only want to know which ones drain the breast, and we want to try to preserve the ones that are draining the arm. And so we actually inject 2 different dyes, and one's a blue dye and one's a radioactive dye, and we can separate out those systems. Working
our way down the list, lympha is next.
Lympha is a technique we don't do in New Orleans currently, but it's something that we did whenever I was in fellowship, which is basically the plastic surgeons at the time would kind of dunk the lymphatics into one of the veins to help prevent lymphedema from developing.
Okay, and the last item on the list?
We'll talk a little bit about that in another slide, where we now sometimes don't do complete axillary lymph node dissections, and instead of doing that, we can do radiation, and that has a lower risk.
All right, we will talk about that in a moment. So that's what you're doing.
Right.
What can patients do to lessen their chances of developing lymphedema?
A lot of patients ask about lymphedema. I think it's a major concern that patients have when they're undergoing breast cancer treatment. Some of the things that historically we've told patients is avoid blood pressures, avoid IV sticks, don't use that arm, and really a lot of those aren't the case anymore. You can use that arm. Actually, the more you use it, the better off. Exercise is actually a great treatment for lymphedema. We do recommend avoiding injury to that arm. So if you're gardening, we want you to wear gloves. If you're cooking, we want you to wear oven mitts, because any kind of break in the skin could then increase the risk of infections.
Okay. Blood pressure sticks is something we're hearing more and more about. How does that factor into all this?
So again, I think there's been newer literature that suggests that maybe we don't need to kind of torture women by telling them that they need to avoid using that arm. So anytime we've done just a sentinel lymph node biopsy, which is by far the majority of women nowadays, they can use that arm for sticks if they need to go to the lab or if the doctor's office needs to do blood pressures. We tell them if they have the option, use the other one, but if they're having trouble, they can always use the arm that we've operated on.
Okay. You mentioned sentinel lymph biopsy. Can you tell us how that works and the role it plays with lymphedema?
So that's kind of how we now stage breast cancer. We used to remove all the lymph nodes. Now we only remove a couple. What we do is we inject dye into the breast. It's usually a little radioactive dye, and then that travels, and it's kind of like a GPS for me. It tells me where to go. It tells me which lymph nodes to take out. And by only removing 1 or 2 or 3, we've lowered the risk of developing that arm swelling because we haven't disrupted all of those lymph nodes up underneath the arm.
Is this pre-op or is this happening right before the surgery?
It's at the time of surgery, yes.
Okay. Another tool you use is, you mentioned already, axillary reverse mapping. So how does that work and how is it helpful?
So axillary reverse mapping, basically what we're doing is we're injecting a blue dye into the arm and watching that blue dye then travel up, and it can stain the lymph nodes blue that then drain the arm. And then we inject a radioactive dye into the breast, and then that stains those lymph nodes, which you can kind of see in the diagram, yellow. They're not really yellow, but they're radioactive. They have a signal in them that the other lymph nodes don't have. And if we can preserve the blue lymph nodes, the rate of lymphedema goes down, probably to the range of 1% or so.
Okay. Now, I can see this because I'm looking at it on a slide, but
Right.
when you're in the operating room, how are you able to see all this? What kind of imaging are you using?
None, my eyes. The blue dye literally stains those drainage and lymphatics blue, and we can see it. And then the radioactive dye, we have a little probe in the operating room that tells us which lymph nodes have that radioactive signal in it. It's almost like a little wand.
You can see this from the exterior of the breast?
So we've made a little small incision, and we're actually looking into the basin where the lymph nodes are kind of stored underneath the arm.
Okay. And are there more conservative treatment options?
So yeah, I mean, this is a big push over the last 5 to 10 years or so. Basically trying to say, do we need to do as much surgery under the arm as we used to do? And the answer is no. I think we have a couple of clinical trials that have shown that now. The top one is a trial, it's called the Aimee trial, which basically said, even if one of the lymph nodes has a little bit of cancer in it, up until about 5 years ago, we used to take all those lymph nodes out no matter what. And now we know we don't have to take out all those lymph nodes. We can do radiation, and it works just as well, with about half the risk of lymphedema. Same thing with the trial right under that. That's a different trial called the ACAZOG Z11 trial, and it showed the same thing. If there was a little bit of cancer in one of those lymph nodes, or even 2 of those lymph nodes, we didn't have to take out the rest of the lymph nodes. We could treat it with our standard treatments and lower the risk of developing lymphedema.
And are there patients who just say, Doc, I appreciate all that, but I want to be more aggressive and lessen my chances of the breast cancer returning?
There are, but what I can tell them is that both of those trials showed that by actually taking out the rest of those lymph nodes, you're not lessening that chance of the cancer returning. So I'm putting you at risk for no reason.
And maybe at risk at other things, as
right,
lymphedema, for
but at a
example.
higher risk of having lymphedema.
All
exactly.
right. You're watching Hello Health on WLAE TV. Tonight, we're going to be talking about treatment options, but first, I want to invite our viewers to call us with your questions for Dr. Mackey and tonight's topic, breast cancer and lymphedema. Our number is 504-866-3200. That's 504-866-3200. You can call with your questions right now, or you can send us questions by email. There's our email address, hhquestions@wlae.com. So what is the protocol for monitoring a patient with breast cancer and with lymphedema?
So what we've historically done is basically have the patient come in and just do measurements. So we actually measure their wrist, we measure up by the elbow, and then we measure the upper arm. Nowadays we have some better tests that are a little bit more objective and a little bit better tools. So what we do is we actually measure their arm, and it's little stickers that they put in, almost like an EKG, but it works a little bit differently. And it's giving us numbers, it's giving us readings. And so we do that before their operation. So before we ever do anything.
You've got a baseline.
Right, a baseline. And then we do it again at the 6-month mark, at the 12-month mark, and we monitor it to see if there's any changes. And that picks it up before clinically the patient complains about it.
Non-operative management options would include what?
So non-operative management options, which is really the mainstay of lymphedema treatment options, include skin care, include massage techniques. There's a couple of different massage techniques, and usually physical therapy is going to get involved with that. Exercise. People historically were told not to exercise. We know that exercise actually helps prevent and treat lymphedema. There's different bandaging techniques, and then the compression garments, which is kind of like a compression sleeve, just like people wear a compression hose on their legs for swelling. This is a compression hose for the arm that helps prevent the swelling.
I would assume you're going to start with these and try all these options, and if they don't work, perhaps more aggressiveness is needed.
Correct, yeah. So there's what we call operative management, and that would be the different surgical techniques that we can use to help prevent lymphedema. Commonly, that's liposuction. That's something that really any plastic surgeon can do. That's what the picture on the bottom of the screen represents, which is a pretty good clinical improvement. You're not really doing anything to treat why the lymphedema is happening, but it actually improves the function of the arm significantly. Lymphovenous bypass is something that usually a plastic surgeon who's trained in microvascular surgery can do, where they basically are taking the little microscopic lymphatics and putting them into little veins. And then sometimes we can do lymph node transfers, where they take lymph nodes from a different spot in the body and then re-implant them to help treat lymphedema. The lymphovenous bypass and the lymph node transfer tends to be better for kind of early lymphedema. It's not great for the more advanced lymphedema.
Okay. And you may have mentioned this earlier, but if you did, I didn't hear it, and I'm sorry. About what percentage of patients, breast cancer patients who have operations, will have developed lymphedema?
So classically, we used to tell people probably in the range of 20 to 30% whenever we used to remove all the lymph nodes, which there's a lot of breast cancer survivors out there, so there's a lot of women who are walking around with lymphedema. Nowadays, in the last 20 years or so, we've changed our techniques and we're not doing as aggressive surgery. So I think the risk is actually going to be lower, but it depends on what your treatment entailed as to what your risk would be.
Okay. And really for me, the overriding theme of our discussion tonight, unless I'm missing something, is lymphedema really has nothing to do with, it's more physical in nature than it is with cancer spreading, correct?
Exactly, yes. There is a very, very rare long-term risk of lymphedema called Stewart-Treves syndrome, which can be a malignancy that results from that, but it's extremely uncommon.
Okay. And you have the two kids at home, so you wanted to do something for Halloween. So you brought along a cartoon of sorts where it involves a dragon, right? What is
just
this?
A cute little breast cancer dragon with a mom and her kid saying, "You fight like a girl, Mom." With the sword and the breast cancer dragon.
Yeah, and it looks like the woman
won.
The woman has been the winner. Absolutely.
Right.
Great. Well, we're so happy to have Dr. Aimee Mackey, surgical breast oncologist, back with us on the program to answer your questions, and we're ready to take them now. Here's our phone number again, 504-866-3200. That's 504-866-3200. I believe we still have some lines open. Or you can send us questions by email, too. There's our email address, hhquestions@wlae.com. And we'll have that on the bottom of our screen in the next part of our program. We'll be back with that, your questions, and Dr. Mackey's answers. This is Hello Health on WLAE.
I love taking care of my mom. It wasn't easy at first. She learned how to better communicate her needs.
And you learned how to not ignore yours.
I discovered how to make healthier meals.
And I discovered how much I enjoyed them.
Becoming a caregiver is a learning experience for everyone. Find articles, tips, and tools from experts and others who have been in your place. The Caregiving Resource Center at aarp.org/caregiving.
If I tried to do all that, I'd be laughed out of the house, which might not be a bad thing. Welcome back to Hello Health. I'm Tom Bagwell. Good to have you with us. Tonight we're talking about cancer of the breast with surgical breast oncologist Aimee Mackey. It is Breast Cancer Awareness Month. And let's go to your questions now. Let's start on line 2. Jim is calling us from the North Shore in Slidell. Jim, welcome. You're on with Dr. Mackey.
Hi, and thank you for taking my call. My question is actually for my mother, who's 88. And she had a lymphectomy last year, breast cancer. And during that, they took out 17 lymph nodes, and they were all clear. They couldn't find the sentinel nodes, so they took all of them out. So she has experienced some lymphedema, and they're treating it with bandaging and then some of that kinesiotherapy tape. But my question is there anything else she can do? Does diet, and they did tell her not to exercise. So I'm curious, if that applies to someone like her who had 17 versus someone who just had 1. So, is there anything else we can do? It's not as bad as what you had showed, but it's very uncomfortable for her. And so I'll listen. Thank you so much again.
Thank you, Jim, for your question.
Yeah, thanks, Jim. I think it's a great question. I think we actually recommend exercise now. Usually we actually send all of these patients to physical therapy. They can do different massage techniques. There's a couple of different massage that they can do. The lymphedema they can do kind of manual massage where they're actually milking the fluid up out of the arm. And then that can help. And then once you've kind of gotten it under control, then you put the compression sleeve on, and you really want them to wear that pretty much 24 hours a day. And then you can gradually sometimes get out of that or wear it less. And then exercise the arm. And then depending if she has a lot of scar tissue that's built up where they removed all the lymph nodes, they can do a little bit of a different technique where they try to break up some of that scar to hopefully help improve some of that drainage back out of the arm. Other things that kind of simple things you can do is, when you're at home, elevate it, try to help gravity out a little bit. In an 88-year-old, I'm not sure anybody would be too enthusiastic about doing a bunch of surgical options. But she could see a plastic surgeon, consider liposuction options, but I don't know if anybody would be too enthusiastic. I think it's mostly the conservative management, which is how you would want to go with that.
Jim, thanks for your question. Best of luck to your mother. And he mentioned that they took out 17 lymph nodes. Do we all have the same number of lymph nodes? And is that an aggressive removal?
No, that's about average.
Okay.
I would say on average when we remove lymph nodes, we remove probably about 15 to 20 if we're removing all of them, if we're doing a full dissection. So I think that's about in the ballpark.
How many do we have? What percentage of lymph nodes?
Okay. So we use the anatomy to guide how many we take out or what we're taking out. I'm not in the operating room counting them. I actually am using different structures, and I want to take the tissue that's between there. And sometimes it's 10, sometimes it's 40. It's just using those structures to guide me.
Okay. Jim, thanks again for your question. Let's go to line 3. Herbert calling us from Marrero this evening. Herbert, you're on Hello Health. Good evening.
Thank you. Good evening. Thank you for the program. I'm a married man, and I would like to know the risk for men, and I would also like to know exactly what are you looking for when you're examining the breast, and do you ever get breast cancer right under the arm, under that fatty tissue?
So a couple of questions in there. Let me see if I can answer all of them.
Well, the first thing we probably need to point out is, yes, men do develop breast cancer. Because if you're just listening to the program, you go, what are you talking about? It is, in fact, in a very small number of cases, but men do, in fact, develop breast cancer.
Yes. Men account for about 1% of breast cancers that we see. So annually, about 2,500 roughly men are going to be diagnosed with breast cancer across the country. It's just much less rare. In men, we're not doing mammograms, so we're really only doing physical exam to look for those things. And men are usually diagnosed at a later stage. And yes, men can get lymphedema, similar to the same reasons that women would get it. It's basically just disrupting that drainage pathway out of the arm. So, and then the other question was,
Talk about can breast cancer develop under the arm? I think was his question.
It can. Most commonly what we're feeling underneath the arm is lymph nodes. So whenever someone comes into my office and I'm examining them, I actually examine the whole breast, but I also examine underneath the arm and feeling for lymph nodes. There also is a little bit of breast tissue that kind of extends up that way, where you can develop a breast cancer in that small amount of tissue.
So are you looking for lumps and feeling for lumps?
Yeah, so every time a woman comes to my office, they get a full breast exam where I am basically doing an exam of all of the breast tissue and then also feeling the lymphatic drainage basin. So I'm feeling up by the collarbone, I'm feeling the neck, I'm feeling underneath the arms.
All right. Our phone number is 504-866-3200. That's 866-3200. Line 1 is next. Raymond calling us. Raymond, welcome. You're on.
Hello, thanks for taking my call.
You're welcome.
I'd like to know from the doctor, what does AFFF mean, if I'm saying it correctly? And what is the BRCA1 and BRCA1 gene? And what percentage of ladies that's tested positive for breast cancer have the AFFF designation, and why is that so lethal, particularly in black women? Thank you.
And if you would, hang on a second, because you, again, asked 3 questions, and that's certainly fine. But, we lost him already. AFFF we'll start with. And okay.
I don't know exactly what he was talking about, but I'm thinking he means triple-negative breast cancer, which is more common in African American women, and African American women tend to be younger when they develop breast cancer. Triple-negative breast cancer is a more aggressive variant. It almost always means chemotherapy if it's a certain size, whether or not the lymph nodes are involved or not. But the treatment options are the same for it. In terms of the surgical management options. I think he also talked about the BRCA1 and the BRCA2 mutations. Those are overwhelmingly the most common genetic mutations that we see that contribute to breast cancer. However, only about 5 to 10% of breast cancers that we see are due to genetic mutations. So are due to something in that patient's genes or DNA that's driving that cancer to develop, as opposed to being what we call a sporadic breast cancer. So BRCA1 and BRCA2, yes, the incidence of triple-negative breast cancer is higher in those patients.
Okay. Thank you very much for your call. We appreciate it. Let's go to West Wego. Charlotte is holding on line 5. Charlotte, welcome. You're on with Dr. Aimee Mackey.
Hi, thank you for taking my call. Dr. Mackey, I did have the pleasure of meeting you with a friend of mine who had breast cancer. I am also a breast cancer survivor. And my question for you is, I had 10 of my nodes removed, and of the 10, 3 were positive. But I did not have lymphedema initially. I kind of had what you were explaining about that my sleeve began to get tighter, my rings began to get tighter much later after my surgery. And I was told that by lifting heavy objects that I actually possibly caused the lymphedema. Is this possible when now I hear that you're saying that exercising and weight, the exercises with the arm would be actually healthier than not doing anything?
So I don't think you caused the lymphedema. I think, yes, we sometimes tell women if we know they're going to be really active, if we know they're going to be doing a lot, is it worth maybe putting on a sleeve or doing something to try to help prevent that? Once you've developed lymphedema, then I think exercise becomes important. It's one of those things that, kind of like you said, Charlotte, you don't always notice it right away. It's sometimes, 6 months, a year, even out to 3 years. If you're going to develop it, most women are going to develop it by about 3 years. That doesn't mean it can't happen years after that, because it can. But I don't think it's anything that you did to cause it. I think the biggest risk factor for you was the fact that you had axillary surgery and you had lymph nodes removed for your breast cancer treatment.
Thank you very much, Charlotte. We appreciate your question this evening. I'm Tom Bagwell, and tonight you're watching Hello Health on WLAE. Our guest is breast surgical oncologist Aimee Mackey. Let's get to an email here, doctor. I had a right side mastectomy 15 years ago, 3 lymph nodes removed, which were all clear. Does the number of nodes removed affect your chances of ever developing lymphedema? We'll start with that, and then there's a second part to that question, just a moment.
So the number of nodes, yes, in a way, because you're doing less aggressive surgery up underneath the arm. So it depends on the amount of dissection that you do up there. So usually on average, if you're only removing 1 or 2 or 3 lymph nodes, you're not doing as much dissection. So she should, yes, be at lower risk.
Okay, here's the second part of the question. How important is it to wear a sleeve, and the doctor showed us the sleeves earlier, when flying or being careful about lifting anything with too much weight? And then there's one more question here at the end.
So in terms of flying, a lot of women ask about this. There's actually been a couple of papers recently that suggest that you may not need to wear a sleeve. I think if women have the sleeve and they want to wear it, they're definitely not doing any harm by wearing their sleeve when they're flying, but I don't necessarily think you have to. There used to be some thoughts about the change in cabin pressure, and that was potentially causing the increased risk of lymphedema.
Okay, and I think we answered the other part. After all these years, I think she mentioned maybe 15? Did she say 15 years? I have to go back and check and see, but I think she said maybe 15 years. Is it still possible to get lymphedema?
It is. It's much,
unlikely, though.
It's unlikely, right? Yeah. If you're gonna develop it, it usually happens earlier than that. But that doesn't mean it can't happen. If there's another insult, if there's, if she were to get an infection or a burn or something like that, that could potentially increase the risk.
All right. Our phone number is 504-866-3200. That's 504-866-3200. There it is on the bottom of our screen. And you can also send us questions by email, as Linda did. And there's our address, hhquestions@wlae.com. And we do have phone lines open. So what happens if someone gets it and chooses not to receive treatment for lymphedema?
So it would likely just progressively get worse. And what happens is the arm really becomes painful and heavy, and they tend to not use it. And then it's just not an ideal situation. It can be really uncomfortable
Additional
for patients.
complications could result from that as well, I would imagine.
Yes.
Okay. Here's another email question, doctor. I had a lumpectomy. Am I at risk of developing lymphedema?
With a lumpectomy alone, without doing anything underneath the arm, without doing a sentinel lymph node biopsy, or without doing a lymph node dissection, the risk really should be quite low. You are, in theory, disrupting some of the lymphatics in the breast, and that's a whole different entity, but we actually see lymphedema of the breast sometimes, where we've disrupted that drainage, where the breast can't drain like it normally would. But with a risk of a lumpectomy alone, it should be really, really low.
Okay. Again, our phone number is 504-866-3200, and you can call us with questions. We do have phone lines open. Doctor, here's another email question. Does being overweight increase my chances of developing lymphedema?
It does, yeah. We do know obesity is a risk factor for lymphedema. We also know age can be a risk factor. For some women, for some reason, younger women are a little bit less likely to get it, but then also obesity.
Okay, and we're talking about developing lymphedema after breast cancer surgery. Is it possible to develop lymphedema just naturally, without any breast cancer surgery?
Yes, you can actually get lymphedema from just anything that disrupts the lymphatic system. So whether it's an infection, whether it might be a different type of cancer. Other cancers can clog the lymph nodes sometimes and can cause obstruction. And then those are probably some parasites can cause lymphedema. We don't see too much of that in the United States. And then cancer alone can cause lymphedema, so it's not uncommon, or I don't see it that often, thank goodness, but breast cancer involves the lymph nodes, and if a lot of lymph nodes are involved with tumor, even before they've received any treatment, women can come in with arm swelling because the cancer has obstructed that.
Our phone number again is 504-866-3200, and we do have phone lines open. or send us questions by email. Our email address is hhquestions@wlae.com. Doctor, several times you've mentioned there are some recent readings about this or research, so it sounds to me like you're up to snuff and on top of things, and you deal with breast cancer on a daily basis. And you were here a year ago.
Yes.
What are we going to be talking about 5 years from now in the area of breast cancer, and do you think it will ever be possible to prevent it entirely?
I hope so. I think we don't know the cause of breast cancer still. So we know that there are certain risk factors for breast cancer, but we do know that women who don't have any of those risk factors can still develop it. So, I think in 5 years' time, I think axillary surgery will be, maybe a thing of the past. We might be doing sentinel nodes still, but I think doing complete lymph node dissections in women, even with positive lymph nodes, is going to be not very often. I think we're working on doing blood tests to try to detect breast cancer. So I really think, we're making tons of progress, but we're just not quite there yet.
Okay. Let's go to line one. Raymond is calling us back with a follow-up question. Raymond, welcome again. Welcome back to Hello Health.
Yeah, thanks a million for taking my call again. This has been a wonderful show, even though I'm a man. A little latest that's been infected with this. I'd like to know from the doctor, since she's so knowledgeable, is breast cancer high in the city of New Orleans? And what percentage of women that get breast cancer these days don't make it? And what percentage of the women that get triple-negative breast cancer, what percentage of those survive? Thank you very much.
Thank you, Raymond.
So it depends a little bit on the stage. It depends a little bit on the tumor subtype. I think overwhelmingly we've improved in the mortality of breast cancer, on how many women are dying of breast cancer. But inevitably there are still women that are dying of breast cancer, and triple negative is probably one of the more aggressive subtypes that we see. Depending on the stage, I hate giving exact percentages because it depends so much on other factors. But I think, if you're kind of stage 2, which is probably where a lot of women end up presenting, there's probably a 20 to 30% risk of having the disease come back somewhere else in your body down the line. So, there's still progress to be made. I think, there's tons of research out there. There's improvement in some of the treatments that we're doing for the different types of breast cancer.
And Raymond asked about comparisons in New Orleans maybe to the rest of the country,
so
or Louisiana compared to the rest of the country.
I think on average we probably have about the same incidence of breast cancer. We don't do as well in terms of survival. I think there's lots of different reasons why that
Staging,
is.
perhaps?
I think more women have advanced stage. I think screening is probably not as accessible. We have a lot of rural towns, and I think women may not be getting the screening that they need to get. And so we have patients come in with more advanced disease. I think underinsured, we know that those women don't do as well because they're not getting screened like they should. And so I think there's tons of different factors that go into why that's the case. So I think we can definitely make some progress in Louisiana in terms of our survival.
All right, Raymond, thank you. All good questions. Let's go to line 2. Bill calling us next from Metairie. Bill, welcome. You're on Hello Health.
Yes, we have a daughter who is a cancer survivor, and it was recommended early in her treatment that she get a double mastectomy. And I'm just asking, at what point do you recommend that a patient, and it seems like I've heard more patients recently who have double mastectomies, and my question is, at what point do you recommend that procedure?
Thanks, Bill. It's a great question. It's a question that a lot of women ask about. So, I think most women have the option of doing a lumpectomy or a mastectomy. When they elect to do the mastectomy, a lot of women ask, well, I'd rather just remove the other one because I don't want to have to deal with this again. And really, for the most part, there's really no survival benefit to removing the other breast. What I can tell you is that the risk of developing a second cancer, so I'm not so worried about the cancer that's already developed kind of jumping to that other breast. It would be more of what's the risk of another cancer forming in that breast. And that risk is probably in the range of 0.2 to 0.5% per year. So it's extremely low. Younger women have a longer lifetime in front of them, so that risk might add up over time, but I still tell them that there's no survival benefit to removing that other breast.
So when we see celebrities choosing that route, I'm sure patients are coming in and asking about that, right?
So the one exception to everything that I just said is in genetic mutation holders. We do know that their risk is actually much higher. So a lot of genetic mutation holders will elect to remove both breasts, and I think that is a perfectly reasonable thing to do. We have women come in who've never developed a breast cancer who remove their breast preventatively if they know that there's a 50 to 80% chance of them developing a breast cancer.
And you talked about testing. Those things now you can help women determine, right?
Right. So we've started a high-risk clinic where when women come in to get their mammogram, we're asking them a lot of questions and trying to figure out where their lifetime risk lies. And if someone's lifetime risk is over 20%, then we can increase some of our screening. So we can offer MRIs in some of those women. Sometimes we refer those women to genetic counseling to talk about getting tested for the BRCA1 or the BRCA2. And there's actually several other genes that we test for now too.
Okay. Let's go back to our phone lines. Line 3, Dee calling us from Mandeville. Dee, welcome. You're on with Dr. Aimee Mackey.
Thank you. My question is, my daughter just recently had breast cancer and the lymph nodes removed, and she had a double mastectomy, and she's finished radiation, and now they're recommending that she go to physical therapy for lymphedema. Does she necessarily have lymphedema, or is this to prevent lymphedema?
So yeah, another good question. Anytime I remove the lymph nodes, what we do is an axillary lymph node dissection. I recommend those people see physical therapy. They teach them about different precautions that they can do to help prevent lymphedema, a couple of the things that I touched on earlier. And then they'll also sometimes fit them for a sleeve preventatively. So if they know they're going to be doing a lot one day, it's a quality of life issue. We want people to go out and live their lives. So maybe they can wear that sleeve in a preventative fashion if that's what they need to do. In terms of your daughter's risk, by having all the lymph nodes removed in addition to having radiation, both of those things together kind of multiplies the risk of developing arm swelling, of developing lymphedema. So she's at relatively high risk. She's probably in that 30% range, which is a very real number. And so I think I would absolutely do the same thing. I would refer her to physical therapy and make sure that she knew what to look for, what to watch out for, so that if it does develop, we catch it early and can treat it accordingly.
Thank you so much for your call, and best of luck to your daughter. Let's go to line 5, Herbert calling us from Marrero this evening. Herbert, welcome. You're on Hello Health.
Thank you. What do you suggest in the way of diet to prevent these conditions? And once you have these conditions, what do you suggest as far as diet is concerned?
So I don't do too much with diet in terms of lymphedema, but in terms of breast cancer risk, we do recommend eating a healthy diet, fresh fruits, fresh vegetables, avoiding some of the processed foods. All of those are going to be good for you, and they're good for you otherwise too. So I think that that's all very important. Exercise is super important in cardiovascular health, but also in terms of breast cancer risk reduction.
All right. Let's go back to our phone lines. By the way, our phone number is 504-866-3200, 866-3200. There you see it on the bottom of your screen, or we'll show it to you here in just a moment. Or continue to send us questions by email at hhquestions@wlae.com. Line 1 is next. Calling us from Marrero is Quinella. Quinella, welcome. You're on Hello Health.
Thank you. The reason why I'm calling is that what is the best test to take to see if you have that disease, the breast cancer? Because I know someone has told me that they took the regular mammogram, but nothing was found, but she still was feeling uncomfortable. So she went to another hospital, and they did an ultrasound, and they found it. So why are the tests not as accurate?
And you mind if I jump in just a second?
Sure.
Quinn, do I know you?
No.
Okay, because I know a Quinn who has a particular.
It's Quinella.
Quinella. Okay, Quinella. I'm sorry. I know a Quinella who has a compelling story related to breast cancer. So I apologize for putting you on the spot like that. I apologize. And you sound like the friend of mine, actually. But thank you for your call. So let's let the doctor answer. I'm sorry, doctor. I hated to jump in there.
That's okay. So I don't know if there's one perfect test. Nothing's perfect. I think mammograms are very good tests, but we know that there are certain types of cancer that don't show up very well on mammogram. So I think we kind of have to put everything together. I think physical exam is important. I think mammograms are important. I think ultrasounds definitely have their place. So if anybody feels a mass or if anybody feels an area that's thickened, in my practice, they'll get a mammogram, but they'll also get a targeted ultrasound, even if that mammogram is negative, to try to make sure. And nowadays, we also do MRIs for certain women, so really dense breast might get an MRI. So I think there's lots of different options out there. None of them are perfect.
And again, the age recommendation for starting is?
40.
40, okay.
Yearly.
All right. Let's go to line 2. Lawson is calling us from Kenner. Lawson, thank you for your patience. You're on Hello Health with Dr. Mackey.
My wife had a mastectomy several years ago, and she was doing fine until she broke her rotator cuff. And since then, she had a bad case of lymphedema. Did that have anything to do with causing the lymphedema to?
That's a tricky one. When she had her rotator cuff injury, she could have had swelling. She could have had scarring up in that area. And also, she probably had a little bit of limited range of motion. She probably wasn't using her arm like she normally did. So I think there probably could have been a couple of factors that went into that. That alone may not have caused it, but maybe that in conjunction with her prior breast cancer treatment could have caused a little bit of swelling in the area, which could then have disrupted the lymphatics.
So certainly possible, but not a guarantee.
Yeah, I mean, I think that's hard to say without ever seeing her and without knowing what exactly surgery she had and those kinds of things.
All right. 504-866-3200 is our number. 866-3200. You're watching Hello Health on WLAE. Our guest is breast surgical oncologist, Dr. Aimee Mackey. Let's go to line 1. Ann calling us this evening. Ann, welcome. You're on Hello Health.
Is I'm a 5-year breast cancer survivor. Now, can I call your office, the doctor, personally, and go over some things about lymph nodes? Because I'm beginning to have problems in that side after the lymph nodes were gone.
And we're going to set, at the end of the program, we're going to provide you with a phone number for viewers, just for viewers of this program, and feel free to call.
Because my questions.
Go ahead. I'm sorry.
My questions might just take a lot more time and detail. And being a survivor, I've done quite a few years good. Now all of a sudden I have problems with that arm.
Okay. And the other thing I'll do, Ann, is suggest this to you, because I'll suggest this to all of our viewers, especially for a particular doctor like Dr. Mackey. If you would take the time to put your questions, because it sounds like there's more than one, in an email to us, and we probably won't get to that this evening, but in almost all cases, our physicians are kind enough to answer emails and might be able to do that in a more specific way. So maybe rather than just calling the doctor at the office, if you could take the time to do that. Knowing Dr. Mackey as I have for these search attempts, I know she'd probably be glad to answer your email back. But thank you very much, and I hope that will be helpful to you.
Yeah.
So when you came here a year ago and now back a year later, what is your hope that you help prepare this segment for us? So what are you hoping people take away from our program this evening as we wrap things up?
I guess that we're making advances. Nothing's perfect, but I think we've made some progress in breast cancer, and I think it's important for women to know signs to look for breast cancer, but also for complications of the treatments that we do, because patients know their bodies better than anybody else.
Okay. And one more question we're going to sneak in here, an email question. Does radiation always follow a lumpectomy, and are you at higher risk to get lymphedema with radiation? Good question.
Yes. it almost always follows a lumpectomy. There are some circumstances where we can avoid it. Women over 70 with favorable breast cancers, some of our less aggressive breast cancers, we can sometimes omit radiation. And anytime we do radiation, there's an increased risk of lymphedema. It's pretty low, but it's not zero.
All right. I want to thank Dr. Mackey for the wonderful information and education she's provided. Great to have you with us on the program. I hope you're back a year from now. All right. Congratulations to you and your growing family as well.
Thank you.
Well, to make an appointment with any of Ochsner's physicians, including tonight's guest, or to register for any of Ochsner's Hello Health seminars, they take place almost every week across the greater New Orleans area. You can call Ochsner at a special number, the one I mentioned earlier, set up just for viewers like you. Here's the number, 504-842-5669. That's 842-5669. As a reminder, you can rewatch tonight's presentation with Dr. Mackey or any of our Hello Health programs on our website, WLAE.com, and Ochsner's website has lots of them too, Ochsner.org. Just type in Hello Health, that'll get you going. Our thanks again to tonight's guest, Dr. Aimee Mackey. Thanks to Humana and Ochsner, as always, for making our program possible. And our final thanks is to you for your support of our program, Hello Health, and our station, WLAE. Good evening.
The enemies we fight against do not slow down. Cancer is relentless. Diabetes is relentless. Time is relentless. So we are relentless. We lose sleep at night dreaming of solutions for wearable technologies, remote monitoring, advancements, innovations, any weapon to win the fight. We are the men and women of Ochsner, and we are relentless. We're doctors and nurses and dreamers and healers, but above all, fighters. Yes, fighters.
Keep working it.
Because when it comes to your health, good is never good enough. So we do not slow down. Ochsner, innovating healthcare.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.